Hello my dear students, it is today I'm going to make a tutorial about the topic of distribution. So at this pandemic situation of COVID-19, I assure that all of you are staying at home and be safe over there, and try to be much more attentive towards all the tutorials that we are trying to make and we are delivering to you. So this is first I am making this tutorial recording about the distribution, so without wasting of time I'm starting on that. So as if you guys all know that my name is Majumder, your class teacher of biopharmaceutics, and I'm going to take the chapter of distribution, and here it is. In the introduction, first I have to say something, the few words, that is the basic concept of distribution. Distribution, as all of you know, that it is a part of a pharmacokinetic step, and where after absorption the distribution will occur. And with respect to drug, before the distribution going to be happen, the drug has to be absorbed first, because the distribution point will consider from the point when the drug will be available into the systemic circulation. When it is reaches to the blood, from that point the distribution will start. So as you know that whole the pharmacokinetic process is nothing but a movement of the drug, that is a kinetic process. So distribution is nothing but also a kinetic process. In which way? Because during this distribution, the blood, which is the circulatory system of our body, the connective tissue of our body, and which the blood also having a pH of alkaline pH 7.4 approx, which will be stagnant like an alkaline pH nature, and also having a different parts like blood cells are there, blood plasma are there, and but blood also constitution of water part are also there. So it is the aqueous volume is also there. So we will talk about all these things: the volume, the tissue volume, the blood volume, the whole body fluid volume, which is also actually related to this distribution of the drug. In this case, as you have seen that in the first position, look at my cursor that I am showing. Here it is. I am here showing that the disposition. First I have written that the process which will lower the plasma drug concentration are termed as disposition. Disposition itself, you can easily gather the knowledge about it, that what is it's trying to indicate. Disposition, position when going to be dislocated, that is called disposition in short. So disposition is occurring actually in this case of distribution part. Why this disposition is occurring? Because whenever the blood will go into the systemic circulation, it is not going to stagnate over there. It has to move because the blood flow will be there. So that's why, and we have also learned in our previous absorption class that due to this flow of this nature of the blood, the sink condition is maintained. The CS minus CB of the part of the fixed first law of diffusion, which has also been, I have been asked in the previous quiz part, that what is actually its meaning. That its meaning that to maintain the gradient, that which gradient it's maintaining. It's maintaining the concentration gradient, because the concentration will never going to be equilibrium, never going to be stopped. The concentration will never going to equilibrated with both either of the wall of the barrier. As if you are thinking about intramuscular injection, then the border will be the muscle, and in case of oral drug delivery, that the border will be the epithelial gut wall, they present in the GI tract. So same way, like in this way, the drug after absorption, it will not stagnate on that either part of the barrier, because due to the flow of the blood within the capillary, it will flow. So it will flow from that site to the site of action, where that means it is distributed throughout the body. So whenever it will distributed throughout the body, it will goes into that site of action, or it will show its activity according to the specific receptors based to show its pharmacodynamic activity. From that part, the pharmacodynamic process will come out, or the pharmacodynamic concern will be there. But till the drug has to reach to the site of action, it has to flow by the blood. And during this flow of this nature, during this flow of the circulatory system, the drug will not going to stagnate on that site where it has been absorbed. It will goes, so the position will be changes. That's why it is disposition. So in this case, disposition again divided into the disposition will be complete by the two process, or maybe you can say the disposition will be divided into two processes. So the total disposition process will be covered by the two things, that is the distribution and elimination. So here in this part, distribution is come out. So now what is this distribution? Here I have written that the process involves reversible transfer of drug between compartments. Now as you have gone through the study of the compartment that is taken by the HASSAN'S, the different segments are there in the compartment, that is from blood to plasma, then blood to tissues. These are the different compartments are there. So in these cases, reversible transfer, always try to remember that in case of distribution, this is not an irreversible transfer as like in elimination. As you can say that as you can see in the elimination part, irreversible, I have written the term that is called irreversible. Why it is written irreversible? Because there is the hidden thing is that it's nothing but it's so easy to remember. In case of distribution, the reversible transfer means that whenever the drug will be transferred from blood to the tissue fluid, then again it is entered into the tissue to the cell. So again it's showing its activity, then it has to be come out from that cell, it has to be detached from the receptor, then again come into the blood, and then again go through the liver for the biotransformation, so that until and unless the drug will not going to be biotransformed, so it will be not transferred into an eliminating product. Sometimes in case of lipophilic drug, it has to be transferred into a biologically it has to be transferred into a water soluble substances. So that's why it is called biotransformation. It's nothing but a metabolism by doing by the organ, that is the liver responsible mostly. So in this way it has to be transformed and then easily able to cross the barrier of the glomerular filtration and can easily eliminated from the body. But in this case of distribution, this is reversible. The drug is changing its position from one compartment to another, again come into the another compartment, or reversibly return back to the compartment. So that's why it's a reversible transfer, not irreversible. But in case of elimination, unless and until it is reached into the glomerular filtration, when it will reach into the glomerular filtration through the urination, the drug will be permanently goes out from the body. That's why it is called irreversible loss. Elimination is nothing but the excretion of the drug from your body after biotransformation. So that's why in the case of elimination it has been written the process involves irreversible loss of drug from the body. And elimination is again further divided into two processes, that is biotransformation and excretion, because first biotransformation has to be occurred so that it can easily excrete. So this is nothing but a detoxification process. Also you can say the liver is responsible to detoxify the foreign substances so that it can easily cross the filtration by the glomerulus, and the drug will excrete from the body after a stipulated period of time by showing its activity. Otherwise, if it will remain in the body, it will show its toxicity. So here you can see this diagram. In the diagram it has showing that in case of excretion you can see there is no reversible arrow mark, but till over there whenever the drug has been metabolized there is no reversible arrow mark. But in the case of drug distribution in the body to the drug metabolites, drug metabolism to the metabolites, in this part reversible transfer is there, because the drug can be reversibly again changes its compartment, but in these cases it is not possible. So that's why distribution is nothing but a reversible transfer between the compartments, but in case of elimination it is an irreversible loss of the body drug from the body. And to complete the disposition it requires two processes, distribution as well as elimination, and to complete the elimination it requires two processes, that is biotransformation first, then excretion. So distribution is a passive transport process, and the driving force for this process is obtained from the different concentration gradient, as we know from the previous chapter. Of course, for the passive transport, passive diffusion, concentration gradient is the main force. That's why it is called also downhill transportation, right? So by diffusion process, drug concentration will increase within tissue until it reaches equilibrium. That means entering the drug in tissue, then amount of drug dragging out from the tissue. That's why it is called reversible. You can see the reversible sign is there, because whenever the drug enters into the tissue, again it can come out from the tissue. And during equilibrium state, the concentration within the tissue depends upon, what is this equilibrium state? Upon which it depends upon plasma concentration, which is proportional to or equals to tissue concentration. So we can see that equilibrium will be attained, or we can see how much has been reached to the tissue. That means we can determine by determining the concentration of the plasma, the concentration of the drug within the plasma, we can determine that much of amount can be reached into the tissue. Okay, as in the previous chapter I have said, how much has been absorbed we can determine by determining by the plasma concentration. We can assume that that much of drug has been absorbed. So uniform distribution never possible. Why? To achieve due to different rate of absorption pattern of drug by the different tissue from the blood. So whatever the drug will be goes into the blood, whole blood or all the molecules are not going to be intact or in an unchanged form. Few of them will be made in unchanged form, but due to presence of numerous cells and other components present in the blood, they are going to attach to the drug components. So they become macromolecules. Some of them are not able to cross the barrier of the capillary membrane, which is also act as a barrier. We will come to the point of the barrier that is also a physiological barrier. Same as like the drug molecule will face the barrier when during the absorption part as a gut wall or as a muscles, whatever. So in this way, uniform distribution never can be possible. But we can determine, by the presence of the unchanged form of the plasma concentration of the drug, we can say that that much of amount can able to enter into the tissue. So that's why plasma concentration equilibrium within the tissue depends upon plasma concentration is equal to tissue concentration. So here is again the concern. If everything will go into smooth, then this outcome will be the smooth. But all the time, according to a physiology of our body, which is not so smooth or not so easy, so due to this physiological factors, or by the factors which is also acting upon the dissolution, the physico-chemical property of the drug also affecting the distribution process. As we have seen, those things are, some factors are also there which are responsible for the absorption of the drug, which can also produce their effect or impact upon the absorption of the drug. Same way, some factors are also there which is also affecting the distribution of the drug. So what are these? Broadly, the distribution, the factors which can affect upon the distribution, it is broadly divided into 4 classes. So differences in drug distribution or its concentration among the tissue essentially arise due to various factors. And these factors are, first one, the tissue permeability, the second one, the tissue size and perfusion rate, third one, the binding of drugs to tissue component. As I have told you, whenever the drug will be reached into the systemic circulation, so many blood components are there, maybe the cell, the proteins or other things which is present within the blood, it may get attached with the drug molecules, and which also create an impact upon the distribution of the drug as well as the miscellaneous factors. So each of these parts we will discuss elaborately one by one. So first of all, come to the point of tissue permeability. In this case of tissue permeability, the tissue permeability again divided into 2 subcategories of the factors. The first one is the physicochemical property and the second one is physiological barrier. So as if we can easily getting our point of this physicochemical property, that earlier also we have studied in the absorption chapter. That physicochemical property is nothing but the physical and chemical property of the drug itself. So in which state the drug belongs to, as it is an amorphous form, or it is in a crystalline form, or it is in hydrate or solvates, or which kind of drug it is weak base or weak salt or weak acid, which pH it can dissociate as a ion, which pH it is not going to dissociate in an ion, and what its solubility property, its dissolution property, what is the size of their molecules. Everything is nothing but the physicochemical property of the drug itself. So same way, these properties also create an impact upon distribution as like previously in absorption. And the second thing is that the physiological barrier, the most important thing, which is also concerned during absorption. And actually during absorption, actually you can say in case of distribution, when the drug is reached to the site of their action, that means we can say when the blood will take the drug to the nearer to the tissue, then it has to cross the tissue. Then again you can say there is an absorption is occurring from the blood. In that cases the absorption is occurring from blood to tissue. But in case of some with respect to different route of administration, if you consider an IV, an intravascular administration of drug as a bolus, so in that case when the drug goes into the IV bolus, 100% bioavailability we are achieving. That means directly we are introducing the drug into the systemic circulation, so there will be no chances of loss of drug during absorption. So whole the drug will be available into the systemic circulation. But in case of that also, absorption is there, the one absorption phase is there, because when 100% drug is available into the blood due to their flow property, it will distribute it throughout the body. But after distributing throughout the body, it will goes nearer to a tissue. In that case, it has to cross the tissue wall. It's as a barrier. So here is an absorption, same as like when we are consuming tablet, it goes into the system. It is not directly goes into the systemic circulation, it will goes into the GIT in the different part, like in stomach, then intestine, then colon, whatever. So in these cases also, it is not directly into the blood. Initially it has to cross the absorption phase, then again blood, then again absorption. So whenever there is an absorption phase, there will be a barrier. That barrier may be not that much of strong barrier, maybe so smooth barrier, easy to cross the barrier by the respective drug, or sometimes it will be most tight junction of the cells, which will never permit numerous things easily to cross the barrier. So these are the physiological. We will go separately into the physiological barrier also, in the physicochemical property also. So these two things coming under the tissue permeability. That is permeability nature, or the capacity of the drug to permeate so that it can reach at the site of action. Then the tissue size and perfusion rate. Perfusion, okay, next slide we are coming. So here then come into the first point of permeability. So here first what I have prepared a diagram like plus and equals to 1 plus 1 is equal to 2, something like that. So in the blood flows, first one, the blood flows uniformly throughout the body. So, and if we add with that, the differences exist in degree of distribution of blood. Differences exist in degree of distribution of drug. So blood uniformly flowing, but differences exist in degree of distribution of drug. So cumulatively, what it is implying? It's implying that indicates the differences in tissue penetrability of drug. So what actually this part is, total part is saying? The total part is trying to actually I am trying to explain by this smart art is that blood is flowing throughout the body uniformly, because there is no barrier for the blood to flow. If there will be a barrier for the blood to flow, then there is a barrier for the nutrition supply throughout your body. So blood is uniformly flow. We have to take in our mind or in our concern that we are not going to involve with the flow of the blood, any kind of complications, the flow of the blood. We have to consider blood is flowing uniformly, but still there is an existence of distribution, the degree. That means uniformly the drug is not going to distribute it. So what is cumulatively implying that? It's cumulatively implying that means permeability, the ability of the drug to penetrate, the penetrability of the drug, difference is there. Existence of differences is there in the penetrability. That means all drugs are not have a similar penetrability or permeability nature. So this is called permeability. So the process indicates that differences in the concentration of drug within the extravascular tissue fluid or tissue due to permeability rate determining step associated, which are two types mainly: rate of tissue permeability, rate of blood perfusion. That means permeability is become a rate determining step over here. Same as like in the absorption, dissolution is a rate determining step. Same as like permeability, here is the rate determining step. Why? Because if the drug is not able to permeate freely or by any chance of process, that means there is a rate limiting step. And another thing is the blood perfusion. Blood is uniformly flow throughout the body, as I told first. So which organ having a what rate of perfusion? That means in case of cardiac output, lungs are having 100% cardiac output, because the blood has to carry the carbon dioxide to the lung so that it will be expel out, it will be exhale out from the body, and the oxygen should be inhaled. Whole the blood should goes into the lung to grab the oxygen and take transfer throughout the body, because which is most necessary. So which part having a what kind of perfusion rate, how many bloods, what kind of cardiac output is going to at what rate in which organ. So that is nothing but the blood perfusion. So here is the definition. Permeability is nothing but the ability to cross the barrier to get available inside the tissue with respect to time. Physicochemical property as well as the existing physiological barriers can affect upon this permeation. Obviously, the rate of blood perfusion. What is this? Perfusion rate is the volume of blood that flows per unit time per unit volume of the tissue. Per unit time per unit volume of the tissue. So that's why ml per minute per ml of the tissue. So that is the perfusion. So here is the tissue permeability. Tissue permeability is mainly determined by its degree of ionization. The ionization and diffusion of drug into cells decide the pH of blood and extravascular fluid. A drug which remains unionized at this pH values permeates the cells with faster rate. The pH of blood and extracellular fluid generally remain constant at pH 7.4 unless conditions like systemic acidosis or alkalosis. During this acidosis or alkalosis, the pH will be fluctuated. So during this fluctuation, whichever the drug will be in ionized at acidic condition, then during acidosis they will become more ionized, and the drugs which are weak acid in nature, they will be remain unionized from in the alkaline pH. So same in this, until and unless acidosis or alkalosis will happen, the pH will remain constant at the 7.4, and according to the nature of the drug they will remain as a ionic or anionic form. So we also know whenever there is an ionic form, cell wall or capillary wall, they will not permeate easily. Cell membrane also not permeate easily. But due to the presence of some pore, ionized drug also can enter into the extracellular fluid. But it will be retarded to enter into the intracellular fluid by the membrane due to its ionic form. But those are unionized, they can easily cross, and if they are having a lipophilic hydrophilic balance, that is also determined by the partition coefficient, it can easily cross the barrier and available into the intracellular fluid to show its activity. This is nothing but the permeation of unionized and ionized drug cross the capillary and cell membrane, because whenever the drug into the blood, it has to cross first the capillary wall, then it has to cross the cell membrane, then it will be available to the intercellular fluid. Okay. So what is this art? Nothing but depends on the two factors, that is physicochemical properties and physiological barriers. Permeability of the drug can be changed. Molecular size, degree of ionization and partition coefficient are physicochemical properties which can affect upon permeability of drug. Barriers are found in the body that restrict the entry of foreign substances and protecting sensitive tissues, which also create an impact upon permeability of drugs. Only small water-soluble molecules and ions of size less than 50 daltons enter the cells by aqueous filled channels, so the permeability can be achieved. While the larger sized particles can be passed by the special transport system, permeability of the drug will be achieved. So this is nothing but what are the factors can create upon permeability of the drug to be changed. The rate of tissue permeability. Now the rate of tissue permeability depends upon these three factors mainly: polar and hydrophilic drugs, non-polar and lipophilic drugs, effective partition coefficient. So in this case, in case of polar and hydrophilic drugs, they will become ionized at plasma pH, obviously. So therefore cannot penetrate the lipid. So that what we have seen in the earlier picture is nothing but this. So if you go through all these points, it is very easier for you to understand. Now we have to concern about this. What is this effective partition coefficient? In case of polar drugs, in which permeability is the rate limiting step in the distribution, effective partition coefficient plays a vital role. So what is it? This effective partition coefficient of polar drug is the driving force for distribution, can be calculated by following. Effective partition coefficient, how can we calculate that? We can calculate by how much of the fraction at this 7.4 is unionized of that drug into its partition coefficient of unionized drug. By multiplying that, we can get what is its effective partition coefficient, and according to the example over here, whenever there is a effective partition coefficient is higher than 1, is like a near about 2.0, in that cases it's showing that the relative rate of distribution is 80. But in case of stronger acid, that means weaker acids like a thiopental drug having a more distribution nature as compared to the strong acids, because their effective partition coefficient is much less, and that's why their rate of distribution is 1. So effective partition coefficient act upon the distribution of the drug on this way. Thus the thiopental distributes in the cerebrospinal fluid at a rate of 80 times faster than the salicylic acid. Okay. Sometimes also the stereochemical nature of the drug will also influence the distribution characteristics, especially when it has tendency to interact with macromolecules like protein. So tissue localization of certain drugs may be an indication of stereoselectivity in drug distribution. And in the next point that we are coming up to, this is the reason behind the rate limiting step occur between tissue permeability and blood perfusion. The three main reasons, according to me, which is acting upon, that is upon the distribution, that is the permeability will be the rate limiting, perfusion and reason. Actually already we have discussed, but why I have concerned again over there, what is the actual reason behind, what is the hidden thing? Actually in case of permeability, the drug under consideration is ionic, polar or water soluble, then selective beta that restricts the drug's diffusion. So by through all these points, it actually implies that greater the blood flow. How? Drug is highly lipophilic, the membrane across the drug is to diffuse is highly permeable. And whenever there is a more blood flow, faster will be the distribution. Obviously, the organs which are having a more perfused with blood that organ will have a more quantity of drug. So the distribution will be much more. So the contrast, greater the blood flow, faster will be the distribution. But with contrast about the flow also, if the drug will be more in unionized form, they can able to cross all the barrier. So blood perfusion rate, again, as we have discussed. So blood perfusion rate is nothing but the tissue blood perfusion partition coefficient from tissue to blood. So it is also denoted by the KT, that is perfusion rate. So the first order distribution rate constant, that is KT. KT is represented the first order, is a perfusion rate by divided by upon KTB. KTB is nothing but the partition coefficient of tissue and blood partition coefficient. So if we divide perfusion rate by the partition coefficient of the drug, that is tissue blood partition coefficient, then we can able to get the first order distribution rate constant. And the tissue distribution half-life also can be determined. If we get the KT value, then 0.693 divided by KT will give me the value of tissue distribution half-life. That means half of the drug, how much time it will take to be available within the tissue, or it will be going to be distributed. So distribution of a particular drug in a particular tissue or organ depends upon two things basically: the size of the tissue, that is the tissue volume, and the tissue blood partition coefficient, because volume is required. Drug like thiopental, highly lipophilic drug, has a high tissue blood partition coefficient towards the brain and adipose tissue. After IV administration of thiopental, diffusing very rapidly into the brain due to highly perfused organ it is. Because perfusion rate is a concern, so that's why it is saying highly perfused organ. So blood perfusion, this table is much more important. It is segment wise showing you which organs in our body or tissues belongs to a category of highly perfused, moderately perfused, and poorly perfused. You have to remember only this, with their cardiac percentage output, with their perfusion rate per ml per minute, and the percentage of body volume, which part having a high volume, which part having a low volume, body volume. Okay, then blood flow ml per minute, per ml per minute, how much ml is going to flow over there. See the lung, the highest perfused organ. As I have told you, the cardiac output is 100%. So in this like way, as compared to all of these, which one is the most lowest one? Cardiac output, adrenal. Percentage of cardiac output is more less. Percentage of cardiac output is more less. But it doesn't mean it is a poorly perfused area. Because of why? Adrenal is so small glands are there. So their tissue volume, it is not required much more amount of blood. But see the blood flow. So also the perfusion rate. So perfusion rate is actually the concern over here. See, it's gradually decreasing. So as compared to bone, perfusion rate is much more higher in case of adrenal. So that's why adrenal coming under high perfused segment of organ and tissue. Okay, hope so you guys have understand. Just go through this table and it will give you an immense idea about which part or tissue will have a faster rate of drug after administration or due to distribution. Now the physiological barrier part, the most important part. This is, as we have learned earlier, this is the second segment of the first type of factors, that is nothing but our tissue permeability, tissue size and perfusion that we have just finished. So in case of physicochemical property also we have said, In case of tissue permeability, the physiological barriers are there. So what are the barriers are there? We are going through that. But before that, what is this barrier actually? So different types of barriers are present within the body which are actually restrict the entry of the substances within the tissue that enter the blood. So whenever the substances enter into the blood, maybe as a nutrition, maybe as a minerals, or maybe as a foreign substances, as a chemical substance, that is nothing but a drug. Whenever the drug will be able to enter the systemic circulation, all the tissues are not going to accept it so easily, because some barriers are there, like an India-Pakistan border. Every country having a border, because freely accessible thing can also sometimes is harmful. So you can not able to easily go into the Pakistan, or Pakistani persons are not can easily come into the India, even also because there is a process. You have to go through some visa and passport, and you can travel whole worldwide, but by following a process. Same way, our body also having some barriers which is not permeate anything whatever the presence in the blood. There must be a process. They has to follow some process so that they can able to cross the barrier, and this is for the safety purpose actually. So these barriers, that's why the second point is showing these barriers is nothing but the protecting the sensitive tissues from different chemicals that enter the blood by different routes. So types of physicochemical barriers, what are these? Blood capillary membranes are there, cell membranes are there, simple capillary endothelial barriers are there, blood cerebrospinal fluid barrier is there, that is the CSF, testicular barrier is there, blood brain barrier is there. This is most important barrier. This is also more harder barrier in our body. And this placental barrier is concerned about during the pregnancy. So at the first, blood capillary membrane barrier. The capillary membrane barrier is nothing but the barrier which is situated between the blood and the tissue. Blood and the tissue, extracellular fluid. Same pics that I have used in the earlier. So this barrier is act to restrict the entry of the substances into the extracellular fluid. So this also can be measured by passive diffusion process, that is the fixed law of diffusion. And here is same as we have studied earlier, the fixed law of diffusion, that is dC by dt is equal to minus dKa by Vh into Cs minus Cv. Here minus sign is there because of negative sign indicates drug movement from inside the blood capillary into the tissue. Okay, so that's why gradually the concentration is going to be decreased over here. So in these cases, capillary will allow most probably the unionized drug, and whenever some substances, here is the P is denoting. P is nothing but the proteins. What are the blood substances present over there? Whenever they will get attached with the drug molecule due to their affinity between them, then they become more macromolecules. The size will be more increases, as we can see during this complexed size of the drug is less than 50 daltons, so that they can easily cross the barrier. But in case when they have become complex, they become more size greater than 50 daltons, or maybe sometimes 100 daltons, or maybe sometimes 600 daltons. So they are not able to cross this barrier. But whenever there is as an ionic also, they are not attached, they can also able to cross. So here you can see, maybe you have a question, see if it is some kind of ions are getting into the ECF, but they are not getting into the intercellular fluid, then how they will show their activity. As we have learned in the previous section, that ion pair transportation is there, active transportation is there, carrier mediated transportation is there. So by process of this also, ion substances can get entered into the intercellular fluid. And for your information, I have to say that, my dear student, that some ions has to be dissociated. The drug has to be dissociated sometimes in an ion, because some ions are also able to attach with the receptors so to show their activity, but not most of the cases. But It's also a true thing that whenever the drug will be dissociated in more ionic form, then it is retarded its penetration, its absorption, and as well as you can say its distribution to the site of action. So these are the consequences. So many things are there, because this is our typical physiological body, man to man, subject to subject, it is varies. So many things can happen, but we have to stick to the basic things to gain the knowledge. Don't be contradictory with the things, because basic things will clear you the contradictory things. If you will not gain knowledge about the basic things, you will not able to conclude the contradictory position. So same way, there is another simple capillary endothelial barrier is also there. In this capillary barrier blood supplies endothelial barrier blood to most of the tissue, which allows passage of drugs. Okay, same things. Cell membrane barrier, it is easy. Cell membrane also present over there in during our absorption part. So you go through the chapter and you can easily conclude. So blood-brain barrier, this is most important chapter. This is most important barrier. Endothelial cells of capillaries are covered by a layer of glial cells. Brain having a glial cells that have a tight intercellular junction. Okay, intercellular junction providing thicker lipid layer. This layer of glial cells reduces diffusion, penetration of water soluble, and most probably blood-brain barrier are never allowing the water soluble substance, that is the polar in nature. That's why I have written over there the polar natural substances such as sugars. These kind of nutritions they can allow. So the structurally similar foreign molecules can also penetrate the BBB by the same mechanism that we have also studied in our absorption chapter, that are false nutrients. Whatever the some chemical substances act as a drug having a similar structure like a nutrition or like a vitamins or some other things, they act as a false nutrients, and brain can puzzle. They are not going to recognize due to their same structure with the nutrition, so they can easily allow being apolar. So same this way. So this layer of glial cells reduces diffusion, which penetration of water soluble and polar drugs into the brain and spinal cord. Highly, because polar things are dissociated in ionic form and they can give some toxic effect. So highly lipid soluble drugs penetrate the blood-brain barrier, whereas polar drugs penetrate CNS slowly. Weak organic acids like penicillin G, having a pK value of 2.6, are found in completely ionized form in plasma but able to penetrate the brain at a low rate due to poor lipid solubility. This is a contradictory thing. This is a deviation. So you have to learn also the deviation. Moreover, the presence of special cells called astrocytes. Here you can see the basement. Moreover, the presence of special cells called as astrocytes, which are the element of supporting tissue found at the base of the endothelial membrane from a solid envelope around the brain capillaries. Capillaries, they are surrounding the capillaries, make an envelope. So as a result, the intercellular passage is blocked, and for a drug to gain access from the capillary circulation into the brain, it has to pass through the cells rather than between them. So it is very difficult for non-polar drugs to get. Highly polar drugs can easily cross the blood-brain barrier because due to tight junction of the basement, due to the presence of astrocytes, and they are making an envelope through the capillaries present in the brain, they are not allowing all kind of drugs, especially the polar drugs, to enter into the brain. And this is the main structure of the blood-brain barrier. Now coming to the point of this is most important chapter of the blood-brain barrier. So I have taken the snapshot. As I have written also, this is the more important because we can also enhance in some cases. We can also enhance the crossing of the blood-brain barrier by the drugs. So what is this actually? This is the use of permeation enhancer. Dimethyl sulfoxide also used sometimes with the formulation to enhance the penetrability power of the drug. Sometimes of osmotic disruption by influencing internal carotid artery with mannitol, and also by the redox system, that is dihydropyridine. So these are the three things which are also administered with the drug to make the drug available to cross the barrier, that is blood-brain barrier. So same as way, blood cerebrospinal fluid barrier is also there. All things has been depicted, all things has been written. So easy for you. The placental barrier. In case of placental barriers, I have to say the one thing is there. that is the trophoblast basement membrane is acting over there, and whatever the things, and the placenta actually is made to supply the nutrition, to supply the oxygens, uh, and also to protect the fetus from bacterial infection. So the blood-rich placenta is joined to the uterine wall of the mother and connects to the baby by way of umbilical cord. So whatever the circulations through the mother going into the fetus, it is done by the umbilical cord, and that umbilical cord is formed from the placenta, and that placenta is attached with the uterine wall. So this is the circulation through the placenta to, through the umbilical cord to the fetus. So whenever the substances, this placenta, it having a thickness, during an early pregnancy, the thickness, wherever it is 25 micron, it is reduced to become 2 microns at the during the 8th week. Where I have written actually that one. Okay, fine. So the thickness will be reduces day by day. So when the thickness will be reduces, some drugs can easily cross the barrier. So during the pregnancy, it has also been mentioned that better to restrict or avoid consumption of drugs during pregnancy due to uncertainty and harmful effects, because drugs may give lethal effect during 2 critical stages during fetal development, and these 2 critical stages are nothing but the first trimester, that is the duration of development of fetal organs, and the later stages. So these are the complications may occur during first 2 is a miscarriage can happen, in some other stages so many harmful effects can happen. So it is better to avoid medications during pregnancy. And this is the testicular barrier, Sertoli junctions are there, this is the circulation towards the testis, and these are the miscellaneous factors. So next part is coming, it is more important than the volume of distribution. Volume of distribution is nothing but that is it doesn't have any physiological meaning actually in case of apparent volume of distribution, but in case of real volume of distribution has direct relation with body water and physiological meaning, which is made up to 3 distinct compartments. That is, volume of each of these compartments can be determined by use of specific markers. And here is the, if you different markers are also there, and which part of the plasma of the extracellular fluid having which quantity of the volume, what are the percentage body weight they are gaining, and regions can be able to determine. Why? By using these markers we can determine that volume of particular that organ or that part of the body fluid. So volume of distribution has to be determined because the concentration can be determined by the volume of tissue, so but which we cannot have true physiological meaning. However, there exists a constant relationship between the concentration, as I have earlier, the concentration, whatever the concentration of the drug in the plasma, we can assume that there is a linear relationship with the concentration of the drug in the body fluid, the tissue fluid. So whenever the drug will be in the concentration in the plasma, that concentration will be available into the tissue fluid, and we can say that that much of amount of drug able to show its activity. So it has been seen that the apparent volume of distribution is nothing but the 2 ratio, that is the amount of drug in the body and the plasma concentration. So Vt is denoted as a volume of distribution, and X is denoted as the amount of drug in the body, and the Cp is nothing but the plasma concentration of the drug. So factors that, actually this is the more important point, factors that produce an alteration in binding of drug to blood components result in an increase in Vd, and those that influences drug binding to extravascular component results in decrease in Vd. So the Vd is a characteristic of each drug under normal condition and is altered under conditions that affect distribution pattern of the drug. So here is the references. Thank you all, and hope you guys can easily understood the part of the distribution up to till that, and the next part will be the binding of the drug with the various proteins which is present in our blood and their affinity, and how can we determine what will be the kinetic of the blood drug protein binding. So here it is. All the best. Thank you.